So our first step here is I'm going to come over around to Jared and check his scans. So this is a motion scan, and this specific area is related to connective tissue of the bones. So he's got one right here. Ear is level of hip, so he has one in his hip, and then that's in his shin, and that's in his foot. So he's got a good amount of strains of bone connective tissue on his right. His left scan actually looks completely different. It looks like he has every bone strain, but that's because he does not have every bone strain. Something is interfering with that scan. So that's what we call a false positive scan. So part of treating is figuring out what is actually worth treating and what is being driven by something else that we need to treat in order to get an accurate scan. In the therapy field, we call those sensitizations. So an example of this is, let's say you came in and ate a bunch of gluten and cheese and your gut was sensitized. If the gut's sensitized, a lot of the scans are going to be saying you have everything. What he has specifically is bone in the right hip, and he has bone in the ankle. So I'm going to raise him up, and we are going to do an assessment. Now, in this assessment, I'm going to check his hip flexion. There's two ways I can check this. One, just the quality of his hip flexion. So as I bring this up, and he doesn't help me, I want him to be loose. As I go, what is the quality of his hip moving inside the front of the space, his femoral head rotating in, and I can feel it kind of pushes me out just a little bit. Okay. The other thing I look for is his belly button. As I bring this up, when does his belly button start to fold? Because that means that I'm getting movement at the low back instead of the hip. So that's the easy general hip flexion assessment. Now what I'm going to do is look at where he has hip flexion, so before his belly button moves. So I could, right there, try to do the assessment, but he's already moving through the spine, so not a very good quality assessment if I do it there. So I'm going to do it here. That's his external rotation. That's his internal. And right now he doesn't really have much internal. So the hip treatment that I might do for the bones of the hip would likely increase hip internal rotation. That would be our goal, because if we're treating to the measures of what we're having as an evaluation. What I really came to do with Jared, because I can get internal rotation doing some things, is help him with some of his shin and foot dysfunction. But we might do some hip while we're here first. So how would we assess the shin and the foot? Well, internal rotation is associated also with knee extension. So in order for me to lock my knee out, I actually have to turn this bone in, and this has to straighten. If I don't have hip internal rotation, I'm going to have a hard time getting a straight leg raise unless I just elongate and hyperextend everything on the back side of my body. And so in this case, when I do this straight leg raise, I go, oh, he's actually got a pretty decent straight leg raise for someone with no hip internal rotation, which means he's probably stretched the backside of his body. But I could also be more strict on my assessment. So in this case, I'm going to go, Jared, you're going to have to hold your foot there like it's against the wall. So that's neutral. And then I'm going to redo this straight leg raise and look for when I see something twist in the body. And now it got tighter. Okay. So we got to think all our assessments are relative, which means that it's very easy to do an assessment and think, well, someone doesn't have any problems. It's kind of like blood work. Oh, you're perfectly normal, even though you have all these problems. It's relative to something else, and it's all just information. So in this case, my spectacular almost 90 degrees leg raise was not really 90 degrees once I got this hip in neutral. Go and relax. So what that tells me is, really simply, is that if I put Jared in neutral, he's going to have a difficult time moving. I don't know if you ever had that experience, Jared.
Mm-hmm.
Okay.
Yeah.
But if I let him orient out, turn into ER, compensate on this side, he could probably get some movements. Okay? Now, what do I want to do with that information? Well, from a manual therapy perspective, as he lays here, I can actually see his left leg is more anterior than his right leg, which means one is back and one is forward. So this is his left leg, it's forward, right leg back. Very common for people to have all sorts of distortions like this. Our goal is not to make someone look perfect, because that doesn't think about the system that's going on with the body. Our goal is really to help the system move more effectively and have more options based off what we're trying to accomplish. In Jared's case, we're trying to get more internal rotation so he can put more pressures down into the ground. We have concluded that his ability to put pressure in the ground is diminished if he has this side in neutral. And if I come down to his shin, which you probably won't be able to see on camera, but his shin actually turns out about halfway. Okay, it's very normal to have bowing in bones, and that's what that assessment's telling me. Now this takes a big wingspan, because I have to be able to get to his scan here and say, okay, that's a lower extremity bone strain, and then if I compress here, does that loosen? And it does. So I can use that scan and diagnostic, what we call palpation here, to just change that temporarily. So right now I know the bone scan in his leg is related to this bending here. So then I am going to raise the table so it's easier for me to work on him. And I want to reduce some of this bowing. Why? Because it made the scan better, and two, I know he has a strain. So right there, am I a little tender, Jared? Mm-hmm. Yeah. Okay. Is a tender point for having a internally rotated and flexed bone. So what I'm going to do is I'm going to actually come into the back of his shin. I'm going to flex his shin by slowly sinking into the bone. And then I'm going to internally rotate it. So I'm turning it this way. And I'm monitoring with I'm using my thumb in this case, but usually I use a finger. Thumb fits the shape of his bone better. A pumping sensation, and I feel a pumping sensation. That pumping is the draining of toxins out of that location. So I have two hands going, my left hand's doing the treatment, my right hand is monitoring that the treatment is being done correctly. So I'm feeling that. Now it's very common with the bone strain that you have opposing twists. So the front side of his tibia, which is his shin bone, is coming forward and in. Either we're going to have something that followed that below, or something that followed that or tried to resist that above. We can use our scan to go back and check that, or we can do motion testing of the bones. So there is lots of ways that you can get information about the body. Because we already looked at the scan, I'm going to check the scan, but I'm going to show you the motion testing, since it makes for a better demo to show more things. So now we go here. How's that tenderness, Jared?
It's lessened.
Okay, so we have a decreased pain sensation. I'm pushing on it pretty hard too now, because you can see I can.
Like it's still tender, but it's not as
tender.
Yeah.
Yep. And this is another thing that a lot of people that maybe aren't manual therapists that do fascial work may not have been taught or are aware of, is that every layer of your fascia has a different tender point. So the bone ones are deep. Those are like a deep pain, like way back in there. But there's superficial right there, and he'll feel that one because he's got fluid tender points. So I can come to the inside of his calves. These are called perforator tender points, and he's got this guy.
That one.
All right. So what he's really feeling. See, if I hold the perforator for a second, and I push here.
Yeah, that's intense.
Yeah. What he's really feeling is the perforator, which you can kind of foam roll these out if you know how to. So I usually don't drain perforators on people. I usually try to do the deepest releases. Not to say that that's not helpful. I'll tell you, if I have someone with an ACL injury, a knee problem, I will clear perforators because they cannot clear toxins and fluid down from the knee. It's basically getting shoved back up and it's all stuck. So that's when I will treat a perforator. I treat a perforator for Jared just for the... And it's usually best to scan first before you treat anything. And there is a scan for lymphatics, and it's right here. But the problem that Jared's going to have, and why his perforator won't go away, is that back here, that rigidity, he can feel that, it just doesn't go anywhere. That's his foot veins, and that is his calf perforator. So the foot, the calf will have to dump into the foot. And right now he doesn't have any space in the foot to let this perforator dump, which is probably why he has it in the first place. So if we're playing chess here, we go, well, I would love to treat his perforator for the demo, but I'd actually treat his foot first because that will drain the perforator unless we have it as a sensitization, which means that his foot bones are so twisted that the fluid doesn't drain down, and now we have a blockage of all the other compartments, which is actually what Jared has. So Jared doesn't just have lymphatic issues here and lymphatic issues in the foot. He actually has bone in the foot. And how would I be able to tell that? Well, I could do it multiple ways. First is I can scan bone of the foot right there. It's stuck. And then if I now pull his lane scan, see how loose that is?
Yeah.
Okay. So my theory was confirmed there that his bone scan is sensitizing his lymphatic scan. So just like I said, if the gut is sensitized, it will back everything up. Same thing with bone in the foot. So here's what we'll do for this demo, is I will find the bone in the foot that is jamming everything, and then we could find a vein in his foot too, which he has one right there.
Ooh.
Okay, so vein in his foot, and he also has the perforator, okay, which he hisses when I touch that one. Okay, so he has all three of these points. And so someone like this would be like, yeah, I have calf tightness, I get cramping, my foot doesn't feel right, all these things. And lymphatic treatments are not going to benefit this specific individual because the torsion is down in the foot and it's in the bone. Okay? So I have different points memorized, but for the sake of this demo, I'm not going to go off points. I'm going to go off of a thinking model. So what I do here is I can first start with his heel bone. And I go, oh, his heel bone is jammed because I cannot bring his heel bone towards the camera. I can only bring it towards his other foot. So I've got a jamming there. So then I go, oh, I got a jamming there. I got this impingement. You can feel that. Okay? That is a bone in the foot. Now what I'll do is I'll touch it. And when we touch things, we do something called therapy localized, TL. And that takes the signal out of the brain for a sec. Why does that work? Well, your brain's electrical, and your fingers have an electrical signal. And so it's interfering with that electrical signal to the brain as long as you're contacting it. So it looks like magic, but it's like a temporary taser. So if I hold this bone tender point, do I get more eversion of Jared's heel? I get some, but what I can feel because I'm experienced is that it drags. I get this motion and then it stops because it catches on his tibia. So his tibia is actually blocking, or his fibula, I would do a different test to figure out which one, is actually blocking this point from getting a full calcaneal benefit. So he could benefit from this one, but then I would have to go up here and clear something in the shaft. I'm not sure that that's what I want to do, or that the heel bone is the one that I want in this case. I could go back up to the scan and confirm it. So the way I would do that is I would go here to this point, and then I would check his foot scan, and look how stiff that is. It did not improve. So that just told me I do not want to fix this, even though it's tender, even though it's rigid, even though he gets more motion. That is not the one that's actually bothering his system. So then I will jump down, and in this case, I will feel around. I actually know where it is already, but I'm walking you through how I would find it. Okay, and I'm here on the medial side, okay? Medial bone. How do I know it's medial bone? Well, I've been doing this for a while, and if you have this shape, like I said, it will pair. So if this is turning in like this, where does all the force go?
Right there.
Right there. Okay, so it's physics. So predictive physics will also lead you to it. But I'm showing you the manual therapy way of how I was taught to find these before I had predictive physics as part of the things that I could play with, okay? But now I'm going to use my manual therapy training and go back up here and go, hey, does that loosen?
That's softer.
And Jared notices right away, oh, it went away. Yeah, okay, so what is the body really trying to deal with when you do manual therapies? Predictive physics. That's all it's trying to do. It's going, there's a force being exerted onto me. I don't have the movement options. So what am I going to do? I'm going to create some kind of compensation that allows me to do that so I can accomplish what I want. Now, there are certain checks in physical therapy systems. And in this case, the heel being able to invert and evert is a desirable quality. A lot of therapists would say, you want that for ground contacts. So now I'm going back into this space, and look, I can also get a heel eversion. And where does that go up to now? Where's the restriction at? It's actually in his knee. Okay, so I can get the turn until you actually see his knee turn. If I go here to this first one, it doesn't go into the knee. You feel that, Jared? It stops in the shin.
Yeah.
If I go here, it goes all the way into the knee.
Yeah, I start to feel it like up here.
Yes, because that's his next strain point. Remember I said there's one above and below. So he has a femoral torsion, he had a tibial torsion, and he has an anterior medial, I don't remember all the bones of the foot, but anterior medial bone strain of the foot. So I'm going to talk about motion checking, which is a different manual therapy modality or technique or assessment diagnostic tool. So in this case, I actually push this bone backwards, and I go, is there any bounce here? There's a little bit of bounce. I push it forward, no bounce. So which way is the joint stuck? Well, it's stuck in the way that it wants to go. So it will not go forward. So typical manual therapist or physical therapist might say, oh, we don't have any forward glide. We're just going to mobilize this or do exercises or get a band and work on forward gliding. When you treat with strain reflex, which is a different set of rules and different way of thinking, is you realize that the body is intelligent. And so what it does is it protects itself into the direction where it has a spasm. So an example of this is like anyone with trauma, emotional trauma, life trauma. They say, I'm afraid of the dark. Let's make something up that's not triggering for people. I'm afraid of the dark. What you don't do is say, well, I'm going to turn all the lights off until you feel more comfortable with it. That's exposure therapy, okay? What you usually do is you talk to them about what is going on with their experience with the dark until they feel more resolved with it, and then they'll go into the dark and they have a better experience, rather than just shutting all the lights off. Same thing with the body. If the ankle right here, his medial foot bone says, I'm not going to let you bring me forward. Feel that, Jared? It's just like, hates that.
Yeah.
I only want to go that way.
Yeah.
If I'm like, oh, well, I'm the smart therapist, so I'm going to do everything I can to crack and bend this and traction this and band this and instrument-assisted tool massage scrape this into a forward position, I'm pretty much doing what that therapist would do if you're afraid of the dark and you just turn all the lights off on someone. I'm doing the opposite of what the person needs. So instead what I do is I know, okay, I motion tested, it wants to go backwards. Can I go backwards towards the camera? More so than backwards towards Jared's opposite foot. So I know that the strain position for this bone inside his anterior ankle is this way and that way. And so I'll monitor this tender point, same toxin pulse. Here, it starts to wobble. While I use my hands, this hand is doing a manipulation. So I'm taking the bones, I'm bending it, and I'm bringing it medial. So now I have created a situation where we're taking the trauma out of his medial anterior foot compartment. And then once I feel that that is resolved, which I can actually feel the tendons, his anterior tendon sheaths. I can feel them changing tonicity, which is good. I'm just going to keep holding that manipulation until it goes away. Why would that happen? Remember I said there's different layers of fascia and we can sensitize fascia. So in this case, what happened was because of the twisting in his ankle that way, his tendons were getting pulled incorrectly. And so they stiffened up and tightened up to create a protective line. And now they're squishy. Now, if you didn't have bone treatments or you didn't understand how this works and you were doing manual therapy or you saw another therapist, they might have thought his tendons or his shin muscles were the problem. And then they'd spend a long time trying to untwist those tendon and shin muscles. Or they might massage those tendon and shin muscles. But if you understand the layering process of how the body works and how things attach, and you have a scan that tells you which one it is, like I do, then you save a lot of time doing that. Okay. And that doesn't really bother Jared as much. Nice and mobile. And then, look, I can pull his ankle forward now. Oh. So what I also will check is the heel twist. Why would I want to check that? Because I want to see what else is going on. Like, how many layers do I need to undo to get my standard physical therapy green light where the person can twist in and out? Okay. The other thing I could do is I go up and actually check his hip internal rotation. Why would that be better? I'll tell you why it would be better. Because when the bone twists all the way up, you get an increased pressure through the entire skeletal system. And an easy way to assess that, I'll do it on this one I haven't treated, you'll see it's really interesting, is I can just tap his foot like he's absorbing force. And I look at where that goes. And on that side, I see the force pretty much stops in his hip. Doesn't make its way up through the body. On this side, I can see it's making it up here now. All that's showing me is force absorption. I could do the same thing with traction. You feel that traction? Kind of a looseness to that. Feel this?
Nothing.
Nothing. Okay. So the one I have not treated, he has no ability to absorb force, down or up. The one I have treated, he's actually getting increased force absorption. I can almost pull his shoulder from the foot. Okay. Now, what I'm going to do for the sake of this demo, and I've only done 2 treatments, by the way. I did one for the shin, and then I walked you through how I found it. Normally when I do these in practice, I do this all without saying anything. I do it super fast. But for the sake of this, you have to appreciate what's happening. So I'm going to go recheck his internal rotation of his hip. See how much change occurred. And you can't see that, but he actually has a soft end field to his IR. So he got a few degrees of hip internal rotation, and we didn't even treat his femur. And we didn't treat his hip. We treated all the way down here and all the way down here. Because that's how the connective tissue works. Okay, so now I could want to resolve some of the dysfunction he has going on through this heel bend. And let's say if my goal was to do that. What are my treatment goals right now? Well, if it was to restore IR, I'd probably come up here and do something for the femur. Okay, but I actually had an intention of treating Jared's extremity because he walks a lot. And since he walks a lot, what is he going to do without impact ability to absorb through the foot and the heel bone? Well, he's just going to retorsion everything up through the chain. So I've seen with Jared, because I've worked out with him before, is that I can get internal rotation back through the hip relatively easy. It's not an impossible thing, but he cannot keep it. Every time he comes back in, it doesn't exist anymore. Why? Because he's got all these torsions through here and he walks a lot. So if I really want to do him the best favor, I'll do this down here. If I just want to do something for Jared for a demo, or because I wanted hip internal rotation, then I'd probably just treat his pelvis, and that would last for a limited amount of time until he walked on this thing again. So let's walk through our thought process on how we treat this now. So I do my heel eversion test, and I notice what occurs is he moves all the way up into the hip. Yep. Okay, so he's getting a twisting. What's happening is the force is going this way. His leg whips like that. That's the force line. Yep. Okay, and right now it's able to go up there, but the heel should move independently of this whole tissue structure, and it's not. Okay? So instead of just the heel moving, his whole leg almost fishtails.
Internally, yeah.
Yeah, he's saying it's internally rotating. Yeah, that is not desirable. So instead what I'm going to do is I'm going to look for, first I'm going to check to see if he has another bone. And he does. It's right there. You can feel that. Okay, so then I go, all right, I could, if I want to be lazy, which usually I do, I just palpate around against that scan, and I'll show you what that looks like. But I'll show you a harder way to find it that you have to think about, because sometimes, you know, it's right there. So this is restricted. You might be able to see that or not, but Jared can feel it. I press here, and all of a sudden, it wiggles back and forth. Isn't that interesting, Jared? Mm-hmm. Okay, now if I go lower on the bone shaft, it's stuck. Lower on the bone shaft, it's stuck. Oh. So none of that helps. So this is the easiest way to locate, is to have the scan and use therapy localization. And so what am I on right now? I'm on his fibular head. So if your fibular head is jammed, it will shove down into the calcaneus and it will compress it, which is what he has going on. So he's got basically a fibular head jam. And in physical therapy, there are little exercises that people try to do for this. I haven't found the exercises work nearly as well as the manual, which is why, you know, I'm a manual therapist. I like it. Okay, so I got to motion check the fibula now. So if I go forward, it doesn't like it. He's gasping at that. Okay, if I, yeah, that's the thing. Okay, yeah. His fibula is hard as a rock, and it's stuck. Okay, now if I didn't know, and when I first started working with people, it's not like I knew all these things. Mm-hmm. I learned these over like 15 years. Is I used to think like, wow, that's a really bad calf muscle. That's a really bad gastroc. It's like, no, that's actually a fibular bone that is twisted and shoved, and so it's taking all the soft tissue and vessels with it, and so you're always having irritated vessels. Mm. It's like the people that foam roll, and every time they foam roll, it always sucks. That's because you're trying to affect something that is far deeper. Okay, so what I'm going to do here is I already know that the position that it does not like is anterior, so the fibula needs to be decompressed posterior. And then the other thing I have to figure out, it's posterior medial, so it's like that way, direction of ease. So I monitor my tender point, I press into, and Jared will tell you, it's like I'm actually pressing deep into the bone, okay? And this takes a while to learn as a manual therapist. If you're a manual therapist watching this, I used to make this mistake. When I first learned fascial treatments, is I would actually blow past the connective tissue or be too shallow. So every layer of fascia that you're trying to affect, you actually have to slowly sink into. And if you do it fast, so Jared can tell you the difference, if I do that, I can get to his bone. If I do this, I'm actually so good I can relax my muscles. If I do this, I don't get it. I'm still superficial. There's a way you have to stack against the connective tissue. It's almost like you're catching something to clean it. It's like a pressure sensation. So my line of direction on my treatment hand is going that way, and he can tell you that that does not suck nearly as bad as it did, and the bone actually changed. So now, after you treat for a while, you can not always need a tender point. You can actually, but what makes counterstrain is tender point and treatment hand. What makes original counterstrain, which if you look up strain-counterstrain, it was not a treatment hand, it was a treatment position. They would actually position someone. So the old way, to actually twist his foot out, relatively internally rotate his shin, externally rotate him here, monitor the tender point, and wait 90 seconds to get as much drainage as I could by positioning, because they didn't know they were treating connective tissue of fascia. They just knew they were treating reflex arc. So they're like, something about this reflex arc, I can position this person to position to get that to soften. And that was the original discovery that Dr. Lawrence, I believe it's Lawrence Jones, created, and I believe that was like in the 70s for strain reflex. But now what we do is we have the scans and the TL, and we can just do it with our hands and find it that fast. That feel better?
Mm-hmm.
Yeah. Okay, and look, he doesn't have all these weird calf vessels back here either. All right, because that was just going along for the ride. So now, it probably feels different.
Mm-hmm.
Now I can ER this better. Now, what I notice, and this is common, is if you had a strain up here that was jamming your fibula, is it that this one up here could cause this here, all the way down here, to have that much problems? And basically what I'm alluding to is that he has another strain that's part of this. Lower down. Lower down. Yeah, you have this one too, but this one wouldn't hold the heel. So if I want this heel assessment to be clear, which is really desirable if you're a physical therapist,
Like here.
that's the one in your femur. The one that I'm actually talking about is your distal fibula. You have a distal fibula one. You see how if I hold that, suddenly I can wiggle it?
Yeah.
So what I was saying is this one was shoved that way, backwards, and his distal fibula is shoved forward, okay? And that distal fibula was compressing his heel bone. So I'm going to treat his distal fibula one. Once again, I could go back to the scan. I could go, yeah, he's still got something in his lower extremity. If I hold here, does it soften? And right away it does. Yeah, he can really feel that one. But see, what his scan is telling me and his body is telling me is all the things I need to clean up to make a happy system. And I have to do it layer by layer based off all the torsions he's acquired. And he'll acquire different torsions based off different compensation patterns. He'll also just acquire them based off what he doesn't have access to. So if he doesn't have IR here, and he doesn't have heel eversion and inversion, every time he goes out, he's going to acquire more of those. Okay, so it's not like your traditional physical therapy measurements and whatnots are incorrect. Like, you still want these hip motions, but are you going to necessarily get them back if you don't fix some of these structural torsions? You may not. Yep, and so in this case,
tender.
So in this case, between his tibia and his fibula, they're trying to spiral backwards. Now, so what actually should be occurring usually is if there's a posterior torsion this way, you might have an anterior torsion this way. But I'm actually doing a posterior treatment. Why? This is a good introduction to scars. So all scarring is modification of the original embryo. So we create scar tissue. We know when we work out that we create scar tissue. We know that when we get surgeries, we actually cut into existing tissue and we get scar tissue. That's like a very different kind of scar tissue. When you strain something enough, you can create scar tissue, and it goes against the normal anatomical direction. And that creates a real dead spot for the brain because it doesn't communicate with the circulation the way that it was originally intended to. So, in this case, scar tissue treatments, they go against the original treatments. There we go. Now you can feel he's got some eversion. Now, where does he have a limitation? So, like I said before, is we've got to clear out layers of this. So now as I turn his heel bone out, which you can't see on the camera, what do I feel actually turns too soon? His foot. So he also has, remember that spot that I found back here earlier that didn't change his scan? He wasn't ready for that treatment before. It wouldn't have really been a benefit. But now, I come into this space, he can feel that. Now he's ready for it. So that's called sequence of treatment. Okay, and that was really important when I learned that, is that if you don't do it in the sequence of the scan, you don't get the outcomes that you think you would get. And so because he didn't scan for this one earlier, I didn't treat it because I knew there is some interference in his connective tissue. But now he scans for this one, so I can treat this one. And what did I have to treat? Well, I had to treat his fibula first. So what his body was saying is, yes, you could try to unload this, but with all this pressure pushing down into the foot like this, that's going to come right back in like 5 seconds. So now his body's saying, you can deload the front of this foot here, and you can get an outcome. And so what I am doing again is I'm going to motion test, and he does not move down. Okay? He can move up. So what's my treatment going to be? It's going to be up, and it's going to be in, and now it's pulsing. Okay, I could also feel like he had like a nub on the bone. It's very common bones will fill with toxins. They'll create nubs and bending and warping, all sorts of things. So this is the opportunity after you get treatments like this to do your heel ankle physical therapy mobilizations after, so that way it stays like that. But it's not going to stay like that if you don't get it addressed down through the chain first. You may get some signal in the system where you try to enforce some of those movements, but you're not going to get the untwisting that you're probably looking for. Okay, good. Okay, now, like I said, this is bone periosteum. That's why I'm motion checking the bone. You can motion check other tender points that are not bone. I'm motion checking his foot into eversion, and it's stuck here. Okay, he can't evert that. He can evert that part. I go, the heel has eversion relative. It moves, 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 stops moving. If I therapy localize, take it out of his system here, and bend the heel bone, it doesn't help. So I'm not going to worry about this part of his foot right now, because I've got either compressive factors here or up above the chain that I'm thinking about more. I'm checking his fibula motion, bringing it around, seeing if he can internally rotate the fibula. He's got some of that now. I also just checked the shape of his shin. You can probably feel that, Jared. Mm-hmm. Actually kind of straight. Let's go to this one. You can feel that bump, how it turns out there. So what that you can't see in the camera, is he's actually got this divot right where his tree is. And that could be a bone strain from getting a tattoo. Okay, because they're pressing in there and they're irritating the fascia. And this shin, which has a lot of nice art on it, you can actually feel when I rub my hand, it goes bump, 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 bump. Could be fascial strains from the tattoos. Bump, 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 bump. And then they're just turning. So there's a general direction and there's a general quality of the tissue. Versus on this one, you can feel how smooth that one is right there. Okay, so you can do what's called a fascial drag test. That is another assessment where you actually run your hands down the fascia. Sticky fascia or things that cling to the skin are indicative of toxin buildups. And I don't say that like, oh my gosh, you need a heavy metal detox cleanse. It's remember what I'm feeling that causes pain. Oh, by the way, we'll go back here. Foot tender point, probably improved. Not screaming. Perforators, he can feel those.
Tight.
Yeah, they're tight, but not as painful. So now we go up to his lymphatic scan, and we go, oh, he can get a perforator treatment now, because he doesn't have all this jamming down here. So I pick out his worst perf right there, gives a little hiss, and we compress from the back where the vessels are, and then we rotate them towards. Now, we also have to remember, like in a perfect world, when you take these classes, they teach you every system like vein, they teach you bone, they teach you system by system. But it doesn't actually really work like that. People don't come in and they're like, I've only got lymphatic tender points, or I've only got bone tender points, or I don't have any scars, or I haven't strained myself enough to create scar tissue acidity to actually get abnormal treatment holds. These are all the things that really throw people for a loop when you're doing manual therapy. So one of the reasons I'm mentioning that is I can feel by the stickiness in Jared's fascia that even though I'm doing this perforator and it's improved his tenderness, he does have this guy here, which is like a type 2 perf. So instead of me, it's either lower, but I have to drain it. No, it's still sticky like that. There it goes. So in this case, my hand had to go this way and in, and usually it's this way and that. Because he has some type 1s and he has some type 2s, which is pretty common. So people coming in for treatments, a lot of times they're like, hey, I've seen a lot of people, why don't I get better? Well, one, we have to figure out what the limitation is in the system. So some kind of motion testing is usually helpful for that. Some kind of diagnostic assessment. But motion testing through the joint, the foot, the spine, whatever the problem is that you're coming in for, you usually have to check that. And then you need to compare it to the scan to make sure that you can treat that in sequence. And before you can do that, you have to make sure the scan is not false positive or sensitized. And then you also have to make sure that you're checking for scar tissue. And then you have to know where you're at up or below the chain. And then you have to consider all the different connective tissue types that you're treating. And those are more bearable, yeah?
Mm-hmm.
Yeah.
Yeah, definitely.
Yeah. And his shin just shrunk down. You can feel his calf because he had just had a lot of vessels there. But once again, like I used to treat people that would come to me just to treat their huge legs for what they would call elephantitis, which is just a lot of swelling. And it would come back because the bones were twisted. Okay, but it's not like you can't get those to drain. But now I don't treat those unless I get the bones straightened. So my goal in today's session was to give him the straight shin. It was secondary benefit would be to increase hip internal rotation or internal rotation measures. It would be to get a heel bone that could get some eversion, which he has some now. Mm-hmm. Okay. And then I want him to do the exercises to maintain that, which we're not going to do the exercises on video because this is a manual therapy demo. And we come back here, come back to his hip, look for hip flexion. Here's his external rotation, actually more limited now. And here's his internal rotation. It's increased. And what's interesting now is that he has taken all this external rotation orientation that he had with no internal rotation. Now he has, instead of this available, he has this available. So he's got a better balance of ER and IR. Okay? And what might be causing this, he hasn't put his foot on the ground yet, but why that might change is that his lower extremity is actually more in line with his hip socket. And if you do that, then you get a better distribution of pressure to both move out and in. And then I will just do one last scan here and see how much that bone scan has improved. And it's pretty nice. I go back to his lymphatic scan and I wiggle that. And there's a little bit more lymphatic there because it's not as loose as his foot. You feel how loose the foot is compared to there. But it's still looser than it was.
So
and his knee.
Are there, like, when you're scanning my head, is that, like, feeling for bone, like, positions that coordinate to different parts of the body?
Great question. So when I'm scanning your head, I have all these charts. I can show them to you, okay? But every line in every direction is a different fascial system. So if I was on your jaw and I pull down, these are tendon veins. So see right here, that's T8. You have a thoracic 8-1. See how stiff that is?
Yeah.
On the other side, stiff. Loose at T9, loose at T9. So you have a T8 or something irritating tendon veins in T8. Okay, so every area of the cranium, like in reflexology, you have the foot.
That's what I was thinking, yeah.
In fascial counterstrain, you have the cranium. And you have lots of real estate on the cranium with lots of systems.
And so some of the strains can be just the fascia, but sometimes they're bone too, and
Of
that's
the
what
head,
we were
yeah.
talking about.
Because I am assessing the cranium. So that right there was your bone scan, and that right there going this way was your lymphatic scan. If I jump down a little bit and go this way, these are your mesentery scans. So your organs, these are connective tissue of your gut. So every place I move can have one, okay? But if I have, like in your case on the left, this is blocked, doesn't move, it's false positive. What could impact this? Well, any of these bones also having a problem. Like most commonly, something like this happening. Something like this happening in the cranium.
Oh.
In the cranium. And there's ways to assess for that. Okay. Creating a false positive. Other option is, obviously, the brain itself is just right here. Right? So if I have swelling in the brain from the inside, and it pressurizes the outside of the connective tissue, it will pick up on the scan. So then what I do, in your case, if I'm looking at the left side, and you come in and you're sensitized, I go, okay, what is this scan related to? Do I have another scan that's close by that could be sensitizing this? Do I have a cranial bone that could be sensitizing this? Or do I have something inside the brain or what's called the dura that's sensitizing this? And then I have to use an assessment process to figure out which one of the three it is, turn that down so I get a clear scan to treat bone on the left side. That make sense?